Myself, Dr. Divya Davison and Dr. Gayathri will be presenting. So question number 1, a 52-year-old man presents with complaints of recurrent headaches for the last 3 months. He describes the headaches as one-sided, throbbing in nature, associated with nausea, photophobia, and sometimes visual disturbances before the pain begins. He has a past medical history of myocardial infarction 2 years ago, for which he is on aspirin and atorvastatin. What is the drug of choice for the acute treatment of this condition? Options are subcutaneous sumatriptan, lasmiditan, C is nasal sumatriptan, and D is risatriptan. Question number 2. A 38-year-old female patient with a diagnosis of episodic migraine. She has failed multiple prophylactic therapies, including propranolol and topiramate due to side effects. After shared decision-making, she was initiated erenumab, a CGRP receptor monoclonal antibody. So question number 1 is list 2 clinical trials that show the efficacy of this drug in migraine prevention. 2. Name 2 adverse effects of this drug. Question number 3. A 29-year-old woman who experienced migraine 2 to 3 times a month planned to become pregnant in the near future and wanted to discuss the treatment options. She was concerned about the possibility of not being able to treat the severe attacks and being disabled by pain. Rimegepant was currently effective and she had only partial benefit from 3 different triptans previously. Which drugs are safe in pregnancy for the acute treatment of migraine? Question number 4. A 59-year-old woman with prior diagnosis of episodic migraine, anxiety, depression, and cervical spine degenerative disease reported a daily bifrontal throbbing headache for the past 6 months. For the management, she used ibuprofen 600 mg to 800 mg daily as needed or acetaminophen 1000 mg daily as needed, with an average use of each medication 4 days per week. She also used oral sumatriptan 50 mg 9 days per month. What is the most likely diagnosis in this condition, in this case? And what should be the next step of management in this case? Question number 5. Among trigeminal autonomic cephalalgias, which one is not responsive to indomethacin? Options are cluster headache, hemicrania continua, paroxysmal hemicrania, SUNC, both A and D. A 47-year-old man experiences excruciating, sharp, and pulsating pain behind his left eye. The pain lasting 15 to 30 minutes is accompanied by rhinorrhea, tearing, and redness of the same eye. These headaches consistently occur at night around 11:30 p.m. and 4 a.m. He also experiences restlessness and agitation during the attacks. What is the most likely diagnosis, and mention 2 other names of this condition? What is the management for this condition? A 27-year-old man presented to the emergency department with nausea, vomiting, and abdominal pain. He had been having similar episodes for the last 7 years, and all of the previous workups had been unremarkable. After excluding all organic causes of his presentation, the patient was diagnosed with a cyclic vomiting syndrome and managed accordingly. What is the diagnostic criteria for cyclic vomiting syndrome by ICHD-3? Question number 8. A 13-year-old male patient presented with symptoms of headache, blurred vision, and left-sided weakness. Prior to his admission, the patient experienced a brief episode of blurred vision followed by a severe right-sided headache accompanied by vomiting. The boy experienced a febrile convulsion at the age of 6 months, leading to hospitalization for fever, headache, and general convulsion at the ages of 4 and 5, respectively, with a subsequent coma lasting 5 to 6 days. He also had a history of right-sided weakness 2 years back, which recovered within 2 days. In his family history, his grandmother has a history of recurrent headaches with motor weakness. This is the image of the patient. What is most likely diagnosis and what is the most probable mutation causing this condition? This is the image showing pathophysiology of migraine. Name 2 neuropeptides implicated in the pathophysiology of migraine. A 61-year-old man with alcoholic cirrhosis, hepatocellular carcinoma, and a smoking history presented with 3 months of blurred vision, periorbital headache, and 15 kg weight loss. On examination, he had left-sided ptosis, miosis, and diminished sensation in the left ophthalmic trigeminal nerve distribution without anhidrosis. CT revealed a parapharyngeal mass encasing the left internal carotid artery with significant narrowing. This is the image. In this image, we can see a ptosis in the left side, and in the CT, there is a parapharyngeal mass encasing the left internal carotid artery. What is the most likely diagnosis and etiologies for the above condition? Syndrome associated with this. This is again showing the pathophysiology of migraine. So identify the molecule given in the diagram A, B, and C. So some molecule is released by trigeminal ganglion, which acts on the perivascular space on the various receptors CLR and RAM1. So identify molecule A, B, and C and give an example for each. A 30-year-old male presented with right-sided facial pain. Identify the marked structures in the given MRI and describe the imaging finding. And enumerate 2 secondary causes for this condition. A 28-year-old previously healthy man presents with worsening headache, confusion, and difficulty walking for the last 12 hours. He had been trekking in the Himalayas and recently ascended to an altitude of 4,500 meters over 2 days. He initially developed a throbbing headache and mild nausea. Over the last 6 to 8 hours, his friends noticed that he became disoriented and had trouble speaking clearly. What is the most likely diagnosis and what is the immediate management? This is the image of the patient. This is on day 5 and this is on day 10. A 35-year-old woman was brought to the emergency department with complaints of persistent headache, lethargy, and lightheadedness for the last 6 hours. They recently started using a kerosene heater in their poorly ventilated apartment due to a power outage. This is the image of the patient. What is the most likely diagnosis? Name 2 other conditions with a similar imaging finding. So this is a phenomenon. Identify this phenomenon. And what is called visual snow syndrome?
Coming to 16th question. This patient is a 60-year-old male with new onset headache, holocranial, lasting 1 to 2 hours, which got exacerbated on coughing. The MRI images are shown. Describe the MRI findings. What is the probable diagnosis? And what are the etiology described for the condition? Next question. 66-year-old female, known hypothyroid, no other comorbidities, presented with recurrent episodes of sudden onset headache associated with transient paresthesia over left upper and lower limb lasting 5 to 10 minutes. This has been lasting for last 3 weeks. On examination, there were no deficits. MRI is shown. Describe the MRI finding. What are the differential diagnoses with this clinical presentation and the MRI finding? Next question. 35-year-old female, diabetic, with history of chronic migraine without aura, presented with acute onset double vision with change in headache character in the form of persistent holocranial headache associated with vomiting. Examination showed right eye ptosis with right eye abduction restriction. This was the MRI. So after this MRI, the routine for etiological workup, routine was normal except for elevated ESR and CRP. CSF study was normal. Vasculitic panel, serum ACE and IgG4 levels were normal. So the patient had presented with a new change in headache character, persistent holocranial with vomiting. Examination showed right eye ptosis with right eye abduction restriction. So with this MRI finding and the other etiological workup being normal, what is the describe the MRI features? What is the most probable diagnosis? What are the differential diagnoses in this condition? Approach to treatment. Describe the approach to treatment. Next question. In a 48-year-old patient with recurrent headaches of 2-year duration associated with neck pain, MRI brain is shown. And T1 post contrast has been shown. CSF study showed total cells of 50 cells with differential count showing lymphocyte predominance with elevated protein. Sugar was CSF sugars was 22 with the corresponding RBS of 127. So what are the MRI findings? What are the differential diagnoses in this case? Approach to further diagnostic workup. T2 and T1 post contrast. Sorry. T2 flare as well. T2 flare and T1 post contrast. Next question, 27-year-old female, known hypothyroid, presented with recurrent episodes of headache with neck pain and transient visual obscuration for 3 years at a frequency of once per month. Few of the events were associated with focal deficits in the form of left upper and lower limb weakness, persisting for 3 to 4 days, and patient recovers to MRS2 after each event. Examination showed vitals normal, cranial nerves were normal. On motor examination, there was mild grip weakness in left upper limb with exaggerated deep tendon reflex in left upper and lower limb with extensor plantar. There was no other deficits. So plain CT and T2 flare has been shown. What is the probable diagnosis? What are the imaging signs described in this condition? What is the management? So this is a 27-year-old female presenting with recurrent episodes of headache associated with focal neurological deficits with examination showing persistent deficit in the form of left grip weakness and exaggerated DTR. Next question. 35-year-old female without any comorbidities presented with bifrontal headache, no postal variation, had red flag signs in the form of visual blurring and vomiting. On examination, patient had left lateral rectus palsy and papilledema. There was no other deficits. Routine and CSF study was normal except for elevated opening pressure. Describe the MRI findings and what is the condition described. What is the diagnostic criteria? The third subdivision of the same question, ophthalmic evaluation was done. What is the investigation depicted in the figure? What is the interpretation? How does this investigation and its interpretation help in decision of in management decision? Next question. 47-year-old male with sudden onset headache, nausea and vomiting. The CT scan has been shown. Describe the CT brain finding. What are the complications possible in the condition? What are the outcome grading scales? Next question. 50-year-old male presented with acute onset right-sided headache with nausea, vomiting, redness and painful eye movements with blurred vision in the right eye. Visual acuity was right eye 6 by 36 and left eye 6 by 12. Extraocular movements was full in all direction. Pupil was equal and reacting. There was no other deficits. Fundus is shown. Describe the fundus finding. What is the probable diagnosis? What are the differential diagnoses in such clinical presentation? Acute onset right-sided headache with painful visual blurring and redness. Next question. 50-year-old male presented with left-sided headache with pulsatile tinnitus. Examination showed no deficits. So MR TOF angio is shown. You can see the DSA images here. Describe the imaging findings. What is the probable diagnosis? Next question, 29-year-old female presented with recurrent episodes of fever with headache and neck stiffness. It recurs around 7 times in the last 10 years, recovering to baseline with symptomatic management. There is no residual neurological deficit. MRI brain and contrast was normal. CSF study showed lymphocytic pleocytosis with elevated protein, and there was no evidence of any hypoglycemia. CSF gram stain is shown. CSF culture, viral PCR, AFB, CBNAT were negative. Autoimmune and vasculitic workup was negative. Describe the marked cells. What is the possible diagnosis? What are the possible etiologies for this condition? Next question. 32-year-old male with history of recurrent headache of holocranial with VAS score of 7 out of 10, lasting for 5 minutes to few hours for past 2 months. Currently presented with recurrent falls and difficulty to walk. GCS was full. On examination, there was bilateral lower limb distal weakness of 4/5 power with exaggerated DTR and extensor plantar. Sensory was normal. With the given imaging, what is the diagnosis? What are the possible complications? What is the management? Next question, 30-year-old female presented with dizziness, eye pain, photophobia and headache, fever and neck pain for 1 week duration. She had a recent prior upper respiratory tract infection. There was history of similar illness in the past. On examination, cognition was normal, no focal neurological deficit, meningeal signs were positive. CSF cells showed lymphocytic pleocytosis and elevated protein. Sugars were normal. Gram stain, India ink, viral and TB PCR was negative. So recurrent episodes of fever, headache, photophobia of 1 week duration with a prior history of respiratory illness with positive meningitis signs and lymphocytic pleocytosis. So what is shown in figure 1 that is associated with this condition? In second figure, what is the clinical finding? What is the immune mechanism resulting in this condition? In the third figure, what is the fundus finding that is usually seen with chronic phase of the disease described? What is the TNF? Which is the TNF alpha inhibitor monoclonal antibody approved for the treatment of uveitis in this condition? Next question, 10-year-old child presented with recurrent unilateral headache. What is the imaging finding? Probable diagnosis? What is the staging of the disease? Next question, 20-year-old female with history of migraine without aura, not on prophylaxis, presented with 3-week history of headache, recurrent headache unilateral with VAS score of 7 to 8 out of 10. Each episode lasting for 3 to 4 days, associated with photophobia and phonophobia. She developed transient right upper limb weakness with numbness and slurred speech lasting for few hours, associated with the last few episodes of headache. There is no history of any preceding fever, no family history. Examination showed normal vitals and no deficits. Routine blood investigations were normal. Imaging, including plain CT brain and MRI brain, was normal. CSF showed lymphocytic pleocytosis with elevated protein and normal opening pressure. Other etiological workup, including gram stain, culture, CBNAT, were negative. Viral panel was negative. Patient was treated with symptomatic management with NSAIDs, to which patient showed significant improvement, and there was no recurrence of such headache with transient deficits. What is the probable diagnosis and what is the pathophysiology speculated? In a patient with history of migraine presented with recent headaches, similar headaches with transient deficits, all other investigations were normal except for CSF lymphocytic pleocytosis and elevated protein. So last question, 57-year-old female presented with left temporal headache with temporal tenderness. What is the specific investigation finding that is shown in the first figure? Second question, what is the ultrasound sign that is described in this disease? What is the mechanism of action of the first monoclonal antibody that is FDA approved for this condition? Now we will be moving on to the answers.
Question number 1 was a 52-year-old man presents with complaints of recurrent headaches for the past 3 months. He describes the headache as one-sided, throbbing in nature, associated with nausea, photophobia, and sometimes visual disturbances. He has a past medical history of MI 2 years ago, for which he is on medication. So question was, what is the drug of choice for the acute treatment? So in the given scenario, it's a migraine headache, and there is a history of MI in the past. So the options given are subcutaneous sumatriptan, lasmiditan, nasal sumatriptan, and rizatriptan. So answer is lasmiditan. It's a novel ditan class. It's highly selective 5-HT1F receptor agonist. So it acts centrally and peripherally. Indication is acute treatment of migraine, and it is available in oral forms 50 mg and 100 mg. And recommended dose is 50, 100, or 200 once in every 24 hours. And no driving or operating machinery is advised within 8 hours after the dosage. This is because despite of good therapeutic efficacy, triptans are vasoconstrictive and hence contraindicated in those with vascular risk factors. So among this, only lasmiditan is 5-HT1F selective agonist, which is approved in this case. Question number 2, a 38-year-old female patient with a diagnosis of episodic migraine. She has failed multiple prophylactic therapies, including propranolol and topiramate, due to side effects. After shared decision making, she was initiated on erenumab, a CGRP receptor monoclonal antibody. List 2 clinical trials and name 2 adverse effects. So we have Liberty trial, Arise trial, and Strive trial. Liberty trial is for efficacy and tolerability of erenumab in patients with episodic migraine. Arise trial is a phase 3 randomized trial of erenumab for episodic migraine. Strive is a control trial of erenumab for episodic migraine. And 2 most common adverse effects related to this drug is constipation and hypertension. Question number 3, a 29-year-old woman who experienced migraine 2 to 3 times a month planned to become pregnant in the near future. The question was, which drugs are safe in pregnancy for the acute treatment of migraine? So for acute treatment, acetaminophen, triptans. Triptans are safe. Metoclopramide, aspirin, diphenhydramine, subcutaneous lidocaine. These are safer drugs. The rimegepant, there are no data available till now. And for lasmiditan also, no data available for the pregnancy. So triptans are safe, and acetaminophen, aspirin, diphenhydramine, and subcutaneous lidocaine. These are the safer drugs. Question number 4, a 59-year-old woman with a prior diagnosis of episodic migraine, anxiety, depression, and cervical spine degenerative disease reported a daily bifrontal throbbing headache for the past 6 months. For the management, she used ibuprofen 600 mg to 800 mg daily as needed, or acetaminophen 1 gram daily. with an average use of each medication on 4 days per week. She also used oral sumatriptan 50 mg 9 days per month. So in this case, question was, what is the most probable diagnosis? So in this case, we can see patient is regularly using the episodic migraine with the bifrontal daily headache, regularly using ibuprofen and acetaminophen along with sumatriptan. So for the past 6 months. So this is a medication overuse headache. This can result from overuse of medication in combination. So management of this medication overuse headache, it usually resolves once the overused medication is withdrawn. So in this case, we can stop ibuprofen and acetaminophen and we can optimize on sumatriptan, oral sumatriptan. So this is medication overuse headache. According to ICHD3 diagnostic criteria, the medication overuse headache is occurring on more or equal to 15 days or more days per month in a patient with pre-existing headache disorder, and regular overuse of for more than 3 months of one or more drugs that can be taken for acute and or symptomatic treatment of headache, and not better accounted for the another ICHD3 diagnosis. Question number 5, among trigeminal autonomic cephalalgias, which one is not responsive to indomethacin? So here answer is both SUNCT and cluster headache. The indomethacin responsive headaches are hemicrania continua and paroxysmal hemicrania. The others, cluster headache and SUNCT are not indomethacin responsive. Indomethacin responsive are hemicrania continua and paroxysmal hemicrania. Question number 6, a 47-year-old man experiences excruciating, sharp and pulsating pain behind his left eye. The pain lasting 15 to 30 minutes is accompanied by rhinorrhea, tearing and redness of the same eye. These headaches consistently occur at night around 11:30 p.m. and 4 a.m. Along with the restlessness and agitation during the attacks. So here the pain is sharp pain, severe pain, duration is 15 to 30 minutes, along with autonomic symptoms on the ipsilateral eye with 1 to 2 episodes per day, along with restlessness and agitation during the attacks. So the diagnosis is cluster headache, and other names of this cluster headache is Horton's headache, histaminergic cephalalgia, and sphenopalatine neuralgia. So according to ICHD3 criteria, at least 5 attacks fulfilling the criteria B to D. The headache should be severe or very severe unilateral, orbital, supraorbital, and or temporal pain lasting for 15 to 180 minutes. And along with the one of the any autonomic symptoms like conjunctival injection, nasal congestion, eyelid edema, forehead and facial sweating, miosis or ptosis, and sense of restlessness or agitation. So the frequency is 1 to 8 per day, and no other diagnosis is in the ICHD3 criteria should be fitting for this. So this is the diagnostic criteria. And these are the trigeminal autonomic cephalalgias: cluster headache, paroxysmal hemicrania, SUNCT and hemicrania continua. So in which cluster headache, the frequency is 1 to 8 and the duration is 15 to 180 per minute. And there will be agitation and restlessness during the attacks. And it is triggered by alcohol and nitroglycerin. And there is no cutaneous triggers. And the management is 100% oxygen and sumatriptan 6 mg subcutaneous. Indomethacin, there is no response. In paroxysmal hemicrania, the frequency is 5 to 50 and the duration is 2 to 30 minutes. And patient will have triggers like nitroglycerin and neck movements. There is no cutaneous trigger and the management is indomethacin. In SUNCT and SUNA, there is an associated cutaneous trigger. And the attacks are 1 to hundreds, and each attack duration is 1 second to 10 minutes. In hemicrania continua, the attack duration, alcohol is an occasional trigger and there is no cutaneous trigger and there is no effect on, and it is indomethacin responsive trigeminal autonomic cephalalgia. Question number 7, a 27-year-old man presented to the emergency department and he diagnosed with the cyclic vomiting syndrome. He had recurrent episodes of vomiting and nausea for the past 7 years. So what is the diagnostic criteria of cyclic vomiting syndrome? So it is a chronic functional disorder. It is classified under the episodic syndromes that may be associated with migraine in the ICHD3 criteria. So it is characterized by recurrent episodes of attacks of intense nausea and vomiting. So at least 5 attacks of intense nausea and vomiting fulfilling the criteria. It will be stereotypical in the individual patient with an recurring and predictable periodicity. And all of the episodes are associated with the nausea and vomiting occur at least 4 times per hour, and attacks last for more than or equal to 1 hour up to 10 days, and attacks are occur more than 1 week apart, and there is a complete freedom from the symptom between attacks. So it may be or may not be associated with migraine. It is classified under the episodic syndrome that may be associated with migraine and is a chronic functional disorder. Question number 8, a 13-year-old male patient presented with the symptoms of headache, blurred vision and left-sided weakness. Prior to his admission, he developed blurred vision and severe right-sided headache along with the vomiting. Boy had a febrile convulsion at the age of 6 months, and there is also history of fever, headache, general convulsion at the ages of 4 and 5, with followed by a subsequent coma lasting for 5 to 6 days. And there is also prior history of right-sided head weakness 2 years back with the family history positive. So this is the image, axial flare image showing. There is in the first figure there is a flare hyperintensity in the right frontal region, and there is a cortical swelling in the bigger figure B, and there is a resolution of this cortical swelling in the figure C. So the diagnosis is familial hemiplegic migraine. Familial hemiplegic migraine type 2. So according to ICHD3 classification, the familial hemiplegic migraine is attacks fulfilling the criteria migraine with aura, and aura consisting of both the following: associated with fully reversible motor weakness and fully reversible visual, sensory, and or speech language symptoms. And at least one first or second degree relative has had attacks fulfilling the criteria. So there are 3 types, type 1, type 2, and type 3. Type 1 is associated with the CA-CNA1A mutation. Type 2 associated with ATP-A1A2 mutation. And type 3 is associated with the SCN1A mutation. In familial hemiplegic migraine type 2, the common mutation is ATP-A1A2 mutation. And it is associated with reversible visual, sensory, and language disturbances, along with various degree of limb hemiplegia. And there will be a history of alternating hemiplegia. In this case, patient had a left-sided weakness with a previous history of right-sided weakness. And the attacks will be severe, maybe severe, and it is associated with the recurrent coma, fever, and even epileptic seizures. And MRI finding, it can be normal, or there can be a hypoperfusion in the initial stages of the hemisphere opposite to the hemiplegia, followed by widespread diffusion weighted image hyperintense signals in the subsequent stage, often accompanied by cortical swelling in the certain patients with the reversibility. So it's hyperperfusion in the initial stages of the disease. So this is the pathophysiology, named 2 neuropeptides implicated in the pathophysiology of migraine. So you all know there are multiple genes associated with this, with gene polymorphism and environmental factors, hormones, menstrual cycle, drugs. All these predisposes the migraine, and there is a followed by hypothalamic activation and alteration in the thalamocortical circuit, altered brain connectivity, followed by brainstem activation and cortical spreading depolarization. following which there is a release of CGRP and pituitary adenylate cyclase peptide. So these acts on the perivascular spaces and causes the migraine symptoms. So neuropeptides implicated in the pathophysiology of migraine, one is CGRP, calcitonin related peptide, gene related peptide, and another is pituitary adenylate cyclase activating polypeptide. So CGRP is a 37 amino acid peptide in C and A delta sensory fibers. It has got widespread innervation in the perivascular localization, and it has got both nociceptive and different roles. And it's a potent vasodilator, effective even at the femtomolar doses. CGRP antagonist is highly effective in the migraine treatment. Another neuropeptide implicated in the pathophysiology is pituitary adenylate cyclase activating polypeptide. It is also present in the sensory trigeminal neuron and modulate nociception at the multiple levels. And in animal and human studies, it was found that this PCAP38 infusion induced marked dilation of extracerebral vessels and triggered delayed migraine-like attacks. And selectively activates PAC1 receptor, and there are multiple trials on this PAC1 receptor antagonist, but no drugs are FDA approved till now. Next question, number 10, 61-year-old man with alcoholic cirrhosis, hepatocellular carcinoma, and smoking history, presented with 3 months of blurred vision, periorbital headache, and 15 kg weight loss. Examination, he had left eye ptosis, meiosis, diminished sensation in the left ophthalmic trigeminal nerve distribution without anhidrosis. So there is a partial Horner syndrome, left-sided ptosis, meiosis, along with without any anhidrosis, and there is a sensory loss in the ophthalmic trigeminal nerve distribution, and there is a history of periorbital headache. And CT showed parapharyngeal mass encasing the left internal carotid artery. So in this case, diagnosis is read as paratrigeminal syndrome. It resembles Horner syndrome and manifests as oculosympathetic paresis with ptosis and meiosis. So unlike Horner syndrome, it has two additional features. One is preservation of facial sweating, because it is on ICA, so it will the pseudomotor fibers goes along with the external carotid artery. So there is a preservation of facial sweating, so there won't be any anhidrosis, and ipsilateral trigeminal sensory irritation producing facial pain. So these are the additional features compared to the Horner syndrome. And etiologies are ICA dissection, ICA aneurysm, or tumors infiltrating ICA. In this case, there is a parapharyngeal mass infiltrating the ICA, left ICA, maybe METS, because patient is a known case of hepatocellular carcinoma. So this is a pathophysiology of migraine showing. And we all know that trigeminal nerve ending, there is a release of CGRP. So there are mainly three drugs. In the therapeutic level, there are mainly three drugs that is acting against CGRP. One is CGRP receptor antibody, one is CGRP monoclonal antibody, and third one is CGRP antagonist. So anti-CGRP receptor antibody is eranumab. And anti-CGRP antibodies, there are drugs fremenisumab, galcanezumab, and eptinezumab. And CGRP antagonists are GPAN group, rimigepant, brogepant, atogepant, and savigepant. So this in question number 12, a 30-year-old male presented with right-sided facial pain. In this image, this is a T2 axial image showing trigeminal nerve and superior cerebellar artery. In this figure, A is superior cerebellar artery and figure B is trigeminal nerve, and we can see there is a bucking in the trigeminal nerve by the superior cerebellar artery. So this image is showing neurovascular conflict. It's a case of trigeminal neuralgia and showing neurovascular conflict. And the secondary causes of trigeminal neuralgia are multiple sclerosis, CP angle meningioma, vestibular schwannoma, and arachnoid cyst. Question number 30, a 28-year-old previously healthy man presents with worsening of headache, confusion, and difficulty walking for the past 12 hours. He had been trekking in the Himalayas and recently ascended to an altitude of 4,500 meters over 2 days. So there is a rapid ascent without acclimatization. He initially developed throbbing headache with nausea, followed by he noticed disorientation and trouble speaking clearly, dysarthria and ataxia. So here the diagnosis, and this is the image finding showing flare, hyperintensity in the corpus callosum, and there is a diffusion restriction on day 5, which gradually improves on day 10. But on day 10, there is a flare hyperintensity, there is a slight increase in the flare hyperintensity. So answer is high altitude cerebral edema. It's a severe form of acute mountain sickness characterized by headache, fatigue, ataxia, and altered mental status. It progressed rapidly to coma and death as a result of brain herniation if not promptly treated. So MRI, there can be T2 flare hyperintensity in the subcortical white matter and corpus callosum. And in SW images, we can see microbleeds in the subcortical white matter. And this multifocal diffusion restriction is usually associated with it's a reversible change. Management is immediate descent of at least 1,000 meters or until symptoms improve, and portable hyperbaric oxygen therapy. You can use IV steroids, dexamethasone, and acetazolamide. Question number 14. A 35-year-old woman is brought to the emergency department with complaints of persistent headache, lethargy, and lightheadedness for the last 6 hours. And the key in this question is recently started using kerosene heater in their poorly ventilated apartment due to power outage. So this is a case of carbon monoxide poisoning. And we can see in this image, there is a flare axial image showing bilateral globus pallidus hyperintensity. So diagnosis is carbon monoxide poisoning. In mild severity, that is the blood concentration, if it is less than 15 to 20%, patient will have headache, shortness of breath, nausea, vomiting, and dizziness. In moderate cases, like concentration 21 to 40%, there is a worsening of headache and confusion, syncope, and chest pain. In severe cases, if the concentration is more than 40%, patient will have hypotension, seizures, cardiac arrest, coma, and respiratory arrest. So what are the other causes of bilateral globus pallidus hyperintensity? Mitochondrial disorders like Leigh syndrome, Wilson's disease, manganese toxicity, and hypoxic injury. These can all cause the similar imaging finding. So identify this phenomenon and what is visual snow syndrome. This is scintillating scotoma or fortification spectra, or also known as tachyopsia. It is a positive visual phenomenon. It's a common visual aura that can precede migraine. It is described as spot of flickering light near the center of visual field, and this prevents the vision and produces scotoma. So this can extend as a shimmering arcs, white or colored flashing lights. Visual snow syndrome is a persistent visual phenomenon. So this is dynamic, continuous tiny dots across the entire visual field persisting more than 3 months. So this is a persistent visual phenomenon, and patient will have additional visual symptoms like palinopsia, enhanced endoptic phenomenon. Enhanced endoptic phenomenon means there are multiple flashes or spotters in the eye, that is endoptic phenomenon, and associated photosensitivity will be there, and impaired night vision, that is nyctalopia. And symptoms are not consistent with the typical migraine visual aura. So patient will have persistent symptoms for more than 3 months, and it is characterized by palinopsia, enhanced endoptic phenomenon, photophobia, and nyctalopia.
Coming to answers of the next set of questions. So 16th question was new onset headache exacerbating on coughing. So MRI, we can see there is posterior fossa crowding with the descent of tonsil, and the prepontine, there is a reduced space in the prepontine space, and there is pachymeningitis with pachymeningeal enhancement with subdural hygroma. So all these features are suggestive of intracranial hypotension. And so these are the typical MRI findings and the possible etiology. In this case, there was an exacerbation on coughing. So this hypotension may be secondary to, we have to suspect a spinal CSF leak. So most common etiology is post lumbar puncture. Other causes are spontaneous CSF leak, skull-based defect due to post-operative traumatic or erosive tumors, where patient can have CSF rhinorrhea as well. Next question, patient had recurrent headache with recurrent episodes of transient paresthesia of left upper and lower limb. So some right hemispheric seizures we have to suspect associated with headache. And this is classically the presentation of, see the MRI T2 flare showing hyperintensity in the high responding area blooming in SWI. So it indicates sulcal SH. So classical differential diagnosis for sulcal SH include RCVS, cerebral amyloid angiopathy, cortical venous thrombosis, angiitis, and vascular malformations like DAVF or AV malformation. So next question was a patient with new onset headache with double vision and examination showing third nerve palsy and sixth nerve palsy. And so the MRI was showing T2 flare hyperintensity, T2 hyperintensity, and the T1 post contrast showing enhancement in the cavernous sinus. So the differential diagnosis we have to other etiological workup like CSF study routine was normal except for elevated ESR and CRP. So any hyperintensity of cavernous sinus indicates it is a Tolosa-Hunt syndrome. It is usually associated with IgG4 disease. Other differential diagnosis we have to consider is cavernous sinus thrombosis, sarcoidosis, venous granulomatosis, lymphoma. For treatment, we have to give IV methyl. After ruling out the CNS infections, we have to provide IV methylpred followed by oral steroids. And if there is relapse, we have to hike up the immunotherapy to azathioprine or methotrexate. Then this question showed a patient with recurrent headache of 2-year duration. We can see T1 post-contrast showing nodular leptomeningeal enhancement as well as pachymeningeal enhancement. And T2 flare showing hyperintensity in the suprasellar region. And CSF study showed neutrophilic lymphocytic pleocytosis with evidence of hypoglycorrhea and elevated protein. So this is features are suggestive of recurrent meningitis with lymphocytic pleocytosis, elevated protein, and hypoglycorrhea. And close differential diagnosis will be sarcoidosis because that first image shows hyperintensity in the pituitary. That may be a lymphocytic hypophysitis. And the other differential diagnosis with this presentation of hypoglycorrhea, lymphocytic pleocytosis, and recurrent meningitis will be TB. Bacterial infections include TB, Lyme's disease, neurosyphilis, brucella, listeria, viral infections including HIV, HSV, varicella, CMV, and Epstein-Barr. Fungal infections including Cryptococcus, histoplasma, and parasitic infections like Acanthamoeba, Balamuthia, toxoplasmosis, or schistosomias. Then other non-infectious conditions include carcinomatous meningomatosis, sarcoidosis, Behçet's, SLE, or idiopathic recurrent meningitis. Then NSAIDs, IVIG, and intrathecal methotrexate can also present with recurrent meningitis. So approach to further workup would be complete etiological workup for infective causes. Complete the CSF study, culture, and fungal, pan-fungal antigen PCR, parasitic PCR, and viral PCR. 2 years. Non-infective. In the setting of chronic history, 2-year history, we have to consider more of non-inflammatory causes. So we have to go for vascularity profile, pathology to rule out Behçet's, serum ACE, and chest X-ray and HRCT chest to rule out sarcoidosis and serum IgG4 levels. And we have to work up for malignancy with PET-CT. So next case is patient with recurrent in malignancy, secondary infective causes and inflammatory causes like carcinomatous meningomatosis and sarcoidosis. Sarcoidosis can also happen. Then this patient is recurrent headache, recurrent meningitis episodes, and some of the events were recurrent headache with some of the episodes associated with focal deficits. And examination, she had persistent weakness. So imaging shows this dense cord sign. So there is hyperdensity in the bilateral transverse sinus, and T2 flare shows hyperintensity in the MCA territory, more of subcortical more than cortical. So this patient was actually diagnosed with cortical venous thrombosis from outside, and she was treated with rivaroxaban. But despite of rivaroxaban, she was having recurrent focal deficits and headache. And on evaluation from here, she was detected to have APLA positive. So she's a case of APLA syndrome. So here diagnosis will be a recurrent cerebral venous sinus thrombosis. Imaging signs include dense clot sign in the plain CT and dense cord sign in the plain CT. So this is also hyperdense deep veins. And in the contrast enhanced CT, we can see the empty delta sign that indicates flow voids, and atypical presentation of the infarcts, like ill-defined non-arterial territory, juxtacortical infarcts, bilateral basal ganglia infarcts with hemorrhagic transformation. They are typically seen in cortical venous sinus thrombosis. So management, we have to look for etiological workup, rule out the predisposing factors like glucocorticoids, infections, and conditions like APLA, protein CS deficiency, antithrombin 3 deficiency. So acute management in any case of CVT will be anticoagulation with heparin, low molecular weight heparin, followed by oral anticoagulation. And maintained for provoked CVT, it has to be continued for 3 to 6 months, unprovoked 6 to 12 months, and APLA, lifelong treatment has to be given. There are only limited trials for endovascular therapy. The recent trial is 2-act trial, which has not shown any significant benefit, like the functional outcome was similar in both medical management and endovascular therapy. Mortality was more actually in endovascular therapy, but bleeding risk was reduced in endovascular therapy. Then surgical therapy by decompressive craniectomy and hematoma evacuation in case of large edematous infarct. And in APLA syndrome, as in this case, we started her on vax are not advised. Then next case is a patient with the bifrontal headache with here we can see the retinal nerve fiber layer, and this is ganglion cell layer. So white, according to the color coding, white indicates thickening. So here there is retinal thickening indicates of papilledema. Ganglion cell layer, as the color coding, red indicates normal thickness and blue indicates reduced thickness. So here optic nerve and optic disc is paired. So that is the interpretation here. There is papilledema with sparing of the optic disc. So how does it help in management decision? The diagnosis is IIH. Diagnostic criteria will be Dandy, modified Dandy criteria. So here, this was the image shown in the question. So this is sparing of optic disc with papilledema. If the optic disc is severely thinned out, then that indicates severe idiopathic intracranial for aggressive management. So that is how OCT will decide in management decision. So next question is a sudden onset headache with nausea, vomiting. CT brain is showing hyperdensity in the sulcal spaces. So subarachnoid hemorrhage. Complications of the condition will be rebleed, cerebral vasospasm, hydrocephalus, seizure, and intracranial hypertension. And the outcome grading scales are Hunt and Hess scale for surgical risk, then WFNS scale, World Federation and Neurological Surgeons grading scale, and Ogilvy and Carter grading system. Next is patient presented with sudden onset right-sided headache with painful visual blurring and redness. So here we can see actually the increased cupping of the optic disc. So this is a case of glaucoma. But the close differential diagnosis in this clinical presentation, we have to consider carotico-cavernous fistula, trigeminal autonomic epiphysealgia, and cortical venous sinus thrombosis. So next question is a 50-year-old male presented with left-sided headache with tinnitus. So the TOF angio is showing. So there is filling of the transverse venous sinus in the arterial face itself. So here we can see the filling of the left transverse sinus in the arterial face, and the DSA is showing the ostial, the dural AV fistula. So here there is early venous filling of the left transverse sinus in the arterial face, indicating of dural AV fistula. So next question was a recurrent headache with fever, recurrent meningitis with no residual neurological deficits in between. So CSF was showing these cells with other etiological workup being negative. There was lymphocytosis as well. So these are normal lymphocytes and monocytes. And the green arrowhead shows monocytes, enlarged monocytes with clover leaf head-shaped nucleus. And these are footprint nucleus. And these are ghost cells. So these are typically activated monocytes, which are seen in, are also called Mollaret cells, which are seen in Mollaret meningitis. So possible etiologies in conditions like HSV and meningitis and varicella meningitis, and autoimmune conditions like SLE, Behçet's, and APLA, they can have these Mollaret cells. They are specific but not sensitive. They are rarely seen. They are also related to genetic conditions like familial matter and fever, TNRP3 and TNF-AIP3 mutation. They are prone to have these recurrent Mollaret meningitis. And this is a new onset headache with recent falls and difficulty to walk. So CT image is showing hyperdensity, indicating of colloidal cyst with obstructive hydrocephalus. So a complication is obstructive hydrocephalus and sudden collapse may occur. So management is VP shunt followed by surgery. Then next question was recurrent fever, headache, and neck pain following respiratory tract infection. And other only apart from meningitic signs, other examination was normal, and CSF was showing inflammatory picture. So associated, there was subserous retinal fluid collection. This is typically seen in associated with Vogt-Koyanagi-Harada syndrome. And this is vitiligo, which the immune-mediated mechanism is antibody-mediated destruction of the melanocytes. That is causing vitiligo. And the fundus picture is sunset glow fundus, which is seen in chronic phase in this condition. So Vogt-Koyanagi-Harada syndrome occurs in various phases. Prodromal phase, patient will have fever, flu-like illness, meningismus. Acute phase, patient will have uveitis. And convalescent phase, patient will have vitiligo, poliosis, and sunset glow fundus. And the treatment of choice for recurrent uveitis is TNF-alpha inhibitor adalimumab. Next question, this is a pediatric patient presented with unilateral headache. We can see terminal ICS stenosis with moya-moya vessels. So the probable diagnosis is moya-moya disease and the staging is Suzuki stage. So these are the initial stenosis is grade 1, stage 1. Then stenosis with appearance of moya-moya vessel is stage 2. Intensification is stage 3. Minimization is stage 4. Further minimization of moya-moya vessels is stage 5. And ECA collaterals is stage 6. So next question was recurrent migraine, migraine associated with focal deficits, with all other investigation being normal except for CSF lymphocytic pleocytosis. So this is a case of headache with, this is a condition called headache and with neurological deficits and CSF lymphocytosis, handle. So this is a rare condition with the probable pathophysiology related to immune response to previous viral infections that has been speculated. This will present like a familial hemiplegic migraine, but on investigation, all other evaluation will be negative except for a CSF lymphocytosis. So last question is a typical history of giant cell arteritis. So this is a temporal artery biopsy. We can see the transmural thickening and inflammatory infiltrates with the presence of giant cells in the tunica, intima, and media. So that is the biopsy shown, and the ultrasound shows the halo sign. That is hypoechogenicity in the arterial wall. That indicates the arterial wall edema. And the treatment approved is tocilizumab, which is an IL-6 inhibitor.
That's all for today. We are ending today's session. Thank you.